Now on to our presentation. I'd like to introduce our presenter for today. Um, Shahla de León. She is the founder of Soil and Sprout. She comes to us as a public health consultant with deep expertise in systems change, equity, and family well-being. She draws from both professional experience and lived experience as a preemie parent. She supports families navigating postpartum and NICU journeys while helping organizations build more healing-centered approaches to care. Her work is grounded in a simple belief, when we care for the people who care for children, children thrive. So please join me in welcoming Shahla de León. It is such a pleasure to have you here with us. I'll now turn it over to you.
Thank you so much, Catherine and Leah. Good morning. And I'm really honored to be here with all of you today. And I have a really deep respect for First Five and a long history of working alongside First Five commissions and partners across California. And over the course of that time, I've been genuinely impressed by the commitment to investing in the healthy development of infants and young children. And I think everyone in this room is here because we care deeply about the well-being of children and families. But we know that babies don't show up to their appointments or to school alone. Their health and development are deeply linked to the capacity of the adults who care for them. So today is really about thinking together about what healing-centered relational support can look like for families and for the people working to support them. I'm really excited to spend this time with you. So, a little more about me. I am Shahla de León. I am a doula, I'm a birth justice advocate, and a public health consultant. As the founder of Soil and Sprout Perinatal, I support families navigating complex pregnancy, birth, postpartum, and NICU experiences. And out in the wild, if you were to find me, it would probably be somewhere between supporting NICU families, lovingly pushing on health systems to advance equity, teaching martial arts, and trying to raise the next generation of kind humans. And my approach is about bringing a human lens to this work because we talk about systems a lot, but systems are made up of people. And people are the ones who shape the norms, practices, policies, and ultimately the experience of every family who moves through those systems. So today, that's what we're really here to talk about, what I call care for the people who care for the people. So as we begin, I'd love to get a sense of who's here in the room today. So in the chat, please take a moment to introduce yourself. I'd love to hear your name, your organization and role if that applies. And I'd also like to just check in terms of how we're showing up today. So using a scale of cats, select the number 1 through 9 that best represents your vibe today. Great. Allison from Alameda Family Services. Allison, I'm a 5 today too. Yelena, welcome. So glad you're here. Oh, yes, we have a 2. We've got a couple of 2s. All right. Love it. Beautiful. And I love that we have such a diversity of roles here today. So glad that everybody could join us. And please keep them coming in the chat. So wonderful. I'm really glad that you all could be here today. So before we go further, I want to invite us to arrive with a brief grounding. For those of us here in Pacific time, many of us are just starting our day, but I bet some of us have already been running around from one thing to the next. And I want to give us a moment to just show up. So let's just take a moment together. If it feels comfortable, relax your gaze or feel free to even close your eyes. Let your feet find the floor. And take a moment to notice the places where your body is being held and supported by the surface beneath you. And let's take one breath in and let it go slowly. And on this next breath, bring a gentle awareness to your breathing. Nothing to change or fix, just noticing. And if you notice any areas of tension, you might imagine creating a little more space around them as you exhale. And after this next breath, I invite you to bring your attention back to the space. Beautiful. Thank you. And as we're bringing attention to ourselves as human beings in human bodies this morning, I also want to set a couple norms for our time together. We love seeing your faces, and we also understand that you are whole people showing up from whole lives. And so if you need to stretch, wiggle, move around, please do. Drink some water. If you've got a baby on your knee, whatever it is, that's okay. The point is meet your needs. That is not a distraction from this training. In fact, that's really part of it. So please show up in whatever way is available to you today. Here's what we're going to do together today. We're going to look honestly at what it's like to be a caregiver of a child with complex needs. We're going to use brain science to understand what might be happening beneath the surface when families seem disengaged, overwhelmed, or hard to reach. We'll talk about what it looks like when someone in this room makes a real difference and what gets in the way of that. And by the end of today, you'll have a new lens for understanding families, practical tools for your work, and a renewed understanding that small moments can have a lasting impact. I also want to name this training applies to all of us here in this room as well, because we are all human, we have a nervous system, and the same principles that we'll discuss today apply not only to the families you serve, but also the systems that support you. And lastly, I want to acknowledge the variety of roles represented here today, looking at the registration information and then this chat. Right here, I see a tremendous range: therapists, family advocates, case managers, early childhood educators, administrators, and others. And so some of the specific examples we'll use today come from healthcare and developmental services. The concepts that we're going to explore are relevant to anyone whose work involves supporting children and families. And so we'll do that today using a mix of case studies, storytelling, some interactive activity, and skill building. Also, you're welcome to use the chat function. We will have some dedicated time for questions at the very end, but you're welcome to share insights, reactions in the chat. I might not see things as they come in, but Leah and Catherine can help me moderate, and if there's questions, we can pause and attend to them. So let's begin with, what is trauma-informed care? Trauma-informed care has become a really important part of conversations in the 0 to 5 world. And I think many of us are still trying to figure out what that actually means for our day-to-day experience. Because trauma-informed care is not just a technique, it's not a certification, it's not one more thing to add to an already full plate. At its core, it's about understanding what a nervous system is carrying and responding in ways that don't add more weight. It shifts one fundamental question. So instead of asking, what's wrong with this person? We start asking, what happened to this person? And what do they need right now to feel safe enough to engage? That shift from curiosity, from judgment to curiosity, changes everything about how care feels and how effective it is. So here's what I want us to hold on to as we go through today. Sometimes what looks like resistance is protection. Sometimes what looks like laziness is exhaustion. Sometimes what looks like non-compliance is overload. Trauma-informed care doesn't require you to know someone's full history. It doesn't require being a therapist. It lives in the quality of everyday interactions. That may be tone, timing, whether someone feels seen or invisible. And I also want to name something before we go further. Trauma-informed care is often described as if it's only for people who've experienced big named traumas, so abuse, violence, loss. But what we know about the nervous system is that chronic stress, the kind that doesn't resolve, the kind that just keeps going, can have the same effect. And that's exactly where we're going to go next. So let's do a quick chat prompt. Before we move on, in the chat, I'd love to invite everyone to finish this sentence. When I'm overwhelmed, I tend to what? Just a word or two, whatever comes up. Sleep, shut down. Oh, yes. Isolate. Oh, my goodness. Yes. Avoidance, procrastinate. Yeah. Yeah. Thank you. Well, this is a beautiful range, and every single one of those is a nervous system doing its job, basically trying to protect you. And that's what we're going to be talking about today for the families you serve and for you. So, the lens I'm using today to talk about caregiver experience is parenting a medically complex child. And I want to be clear, medically complex can mean a lot of things. It might mean a baby born preterm, a child with genetic differences that affect their daily functioning, developmental delays, a chronic condition that requires ongoing management or intervention, feeding challenges. As many of you, I'm sure, know, many of these may cluster together. And it also includes children whose most visible challenge is their behavior. Kids who are dysregulated, explosive, withdrawn, or hard to reach. And these are often the children who draw our attention again and again. So these might be in your caseloads, our classrooms, our programs, and the caregivers supporting them are often carrying something enormous. What all of these situations share is they ask more. More appointments, more coordination, more equipment, more learning, more decisions. And most of what the child needs, the vast majority of it, doesn't happen in a clinic or a classroom. It happens at home, carried out by the caregiver. And alongside all of the logistics, there's an emotional reality, worry, fear, uncertainty, a steep and ongoing learning curve, sometimes guilt and shame. Especially for preemie parents or NICU families that I work with, there can be a profound sense that their body failed. And that emotional weight sits underneath every appointment, every recommendation, every follow-up question. So let's talk a little about what that does to a human nervous system. So our brains are really good at doing what they were designed to do, to scan for safety. But that system isn't especially nuanced. At a basic level, there's tiger and not tiger. And when the body reads tiger, we mobilize. Our heart rate changes, attention narrows, there are shifts in sleep, digestion, cognition, and other functions, all designed to equip us to confront an imminent threat. So our survival system kind of takes the lead. But when we perceive not tiger, the nervous system can settle. The rest and digest system becomes more active. Our bodies can shift out of protection mode and into a state where we can think more clearly, connect, learn, and problem solve. And this is not a failure. This is our bodies beautifully performing exactly what it was designed to do. And honestly, I could talk about this all day, but we'll leave it there for now. But here's what's different for many of the families you serve. For many families, especially those navigating chronic medical needs, the stress isn't short term. There are ongoing appointments, therapies, feeding concerns, uncertainty, disrupted sleep, financial pressure, and constant monitoring. And even when things improve medically, the body, and now I'm talking about the caregiver body, may still be bracing for the next problem. And when stress stays chronic and unresolved, the nervous system has a much harder time returning to baseline. And that shows up in ways that are easy to misread. So let's talk about what activation looks like. In real life, a nervous system under chronic load can look like anxiety, irritability, missing appointments, forgetfulness, difficulty prioritizing, emotional reactions that seem bigger than the moment, numbness, shutdown. And these are not individual character flaws. These are actually pretty predictable adaptations to a sustained load. Some of these resonate a lot with what I saw come up here in the chat. A parent who isn't following through on recommendations, they might be depleted, hypervigilant, or running on empty. So let's take just a moment to name why this matters. So, in addition to the fact that caregivers are people and we care about them simply for their own sake, but additionally, in the context of the first five community, a regulated caregiver is part of the child's developmental environment. When we support a parent's capacity to feel safe and less alone, we're directly supporting the child. And so supporting caregiver well-being is not a side concern. It is child developmental work. So I'd like to use the next couple of minutes to go through a case study. I'm going to share some clinical details first, and I'd like you to just notice what comes up for you as I do. Not what you think you should think, but what you actually think. All right, so baby R was born almost 2 months early at 33 weeks gestation, diagnosed with reflux, tongue tie, and a milk protein allergy. And the baby is showing poor weight gain, sitting right at the second percentile and dropping. And from a care standpoint, in addition to some other interventions, baby R has been referred to occupational therapy for feeding support. So this is where we're going to focus for now. And the OT assessment finds weak suck, poor oral motor coordination, and poor cheek strength. And the recommendation is oral motor exercises at home 5 times a day to improve feeding ability and support weight gain. The parent is present at the appointment, verbalizes understanding, seems engaged, but at a follow-up appointment, the parent has not been doing the oral motor exercises at home. So what happens next? At 8 months, the baby's weight plateaus, and at 9 months, the baby starts losing weight. Baby R is diagnosed as failure to thrive. The baby is hospitalized. And then after an inpatient hospital stay, the baby is sent home with an NG tube for feeding. All right, so I want to pause and ask you something honestly. So in the chat, I'm actually going to ask two questions. First, what assumptions might you find yourself making about this caregiver? No right answers here, but this is just a chance to reflect and be honest with ourselves. Yeah, parent doesn't care enough. Yep. Maybe they need extra support. Maybe lack of understanding. Yeah. And there could be real consequences not showing up in the ways that their child may need to thrive. Yeah, thank you. Thank you for being honest. This is important because whatever came up for you, that shapes how we show up in the room with that family. And we can't work with what we can't see. So again, I appreciate these beautiful and honest reflections. So, second question, let's shift now from assumptions to curiosity. What might be going on for this family? Not what you assume, but what's possible. What might explain what we're seeing? And I'd actually love to hear some voices on this one. So is there someone who wants to unmute and share a thought?
Worked for WIC for about 9 years, so this was not an unusual situation for us to encounter. Um, and so a lot of the families that I worked with, um, they had so many demands made of them that they just had a really difficult time being able to set aside the time necessary to do whether it was OT or PT or whatever as the activity was that they needed to do in order to um, help their child. Um, so that's kind of a challenge because a lot of times it could be something as simple as not having a regular daily schedule for their family, or it could be something, as complex as uh, both parents are working and trying to feed all of the family and just not being able to devote the energy needed to provide the care that the child needs.
Yeah, thank you, Christine. And I see some of that echoed in what Maya added in the chat. Anyone else want to share? Either come off mute for a sec or drop your thoughts in the chat here. Financial stress, family conflicts. I
Yeah.
think I saw Cecilia coming off mute.
Yeah, well, I am just thinking the mother needs a lot of support. Yeah, accompaniment. Who knows what she's going through? Most of the mothers, especially immigrant mothers, are so isolated, and that is key for how they can be mothers.
Thank you, Cecilia. Thank you. I think that's really important. And I appreciate you also bringing in the lens of like sociocultural context. So not only is there the parent and child situation, but there's this whole community and ecosystem and life that's going on for these families. So I want to just take a moment and notice what just happened when we move from assumptions to curiosity, from kind of what's wrong with this person to what might be going on. Something changes. The family goes from being a problem to solve to being a person to discover. And that shift is trauma-informed care in action. All right, I want to ask one more question before we go deeper, and this one is about you. So one more time, let's drop some thoughts in the chat. As the provider trying to support this family, maybe you're the OT, maybe you're a home visitor, case manager, maybe you're the ECE provider. Imagine what feelings might come up for you if you were supporting a family in this kind of situation: frustration, worry, helplessness. I'd love to hear a couple thoughts in the chat.
I feel a sense of emergency. What kind of help the mother needs, and what can we help her with?
Yeah. Frustration and concern. I love these. These are such a mix: sadness and compassion, concern. These are both loving and concern. And I love that we can hold all of those, and all of these feelings are valid. All right. So now let me tell you a little bit more about this family. So first, let's start with the baby's medical picture. So we know baby R is struggling with feeding. He has actually developed an oral aversion and refuses breast and bottle, and feeds only go well under very specific conditions. That might be the right positioning, the right mood, sometimes only when he's half asleep. Every bottle is fortified with a specialized hypoallergenic formula, which is wildly expensive and now means every bottle needs to be used within an hour of preparation for safety. Mom is tracking every millimeter of intake carefully to report to the GI and pediatrician, and there are frequent appointments which constantly disrupt an already fragile feeding schedule. Now, the feeding reality. Mom is exclusively pumping, which means pumping and feeding around the clock, night and day. There is no shortcut and there is no break. She has eliminated foods from her own diet to support the child's GI issues and allergies, but has lost significant weight herself in the process. And every outing requires bringing a pump, bottles, fortifying formula, ice packs, bottle washing supplies. Additionally, milk is frequently wasted, and feeding has become a source of profound stress. Next, the family context. This family has recently experienced a job loss, compounding the already significant financial stress of specialized formula, frequent appointments, and relentless demands of this level of care. And one caregiver travels regularly for military service. And finally, her emotional reality. She's showing signs of depression and anxiety, and she carries a deep, persistent feeling that she's failing her child. Some of you, I think, already intuited that some of these things were coming in your previous comments. So let's just take a breath to hold that. And what, if anything, does this change about our assumptions? And what does it change about how we might understand what this family is carrying. No need to type responses here, but just to sit with this very messy picture here for a moment. Now, let me tell you why I know so much about this family's story. It's because I lived it. I became a parent with a master's degree in public health, a history of working in a healthcare setting, which means I had an understanding of billing and diagnosis codes, and a career built on helping make health systems more equitable, high quality, and accessible. I had written academic papers on the benefits of breastfeeding. I had health insurance, a partner, family support, flexible employment. I spoke the primary language of the spoken language of my healthcare teams. So on paper, I had a lot going for me. And yet, there I was with a child refusing to eat, losing weight, without any clear explanation for why. And I was white knuckling my way through every day. Every time my son was put on the scale, it felt like my worth was being measured in ounces. And when that diagnosis came, failure to thrive, it's a horrible sounding name, it felt like I was the one who had failed. So let me answer the question we started with. Why wasn't mom doing the oral motor exercises? You can already tell I'm a storyteller, so I'm going to paint a little bit more of the picture for us here today. So imagine every 3 hours we had a feeding cycle. Pumping took about 20 minutes, then fortifying the milk to add extra calories. Once that bottle was made, though, the clock started ticking and it had to be used within the hour. And then the actual feeding, which generally looked like offering the bottle, trying again, changing positions, waiting for the stars to align, hoping maybe the wind changed direction, whatever kind of magic was needed for that feed to be successful. And then if he finally accepted the bottle and started drinking, then freeze. Don't move a muscle, don't breathe weird, don't break the spell. Then track the ounces, do some complicated milk math about what stayed in him, what came back out, what had to be tossed because the clock ran out, then write everything down, hold upright for 20 minutes because of reflux, wash bottles, wash pump parts, store the milk, label the milk, rotate the milk, freeze the milk, and then start over every 3 hours. So I don't know if anyone was doing the math in their head, but I think that basically adds up to about 4 or 5 hours of tasks that had to fit in every 3-hour cycle. And the feeding routine didn't fit into the day. The feeding routine was the day. And honestly, that was only part of the problem. The issue wasn't just time. The exercises themselves could interfere with the single most urgent goal, which was getting calories in his body to sustain the growth and development. And they involved taking a baby who was already very guarded and sensitive about his mouth, and then doing a series of exercises involving his cheek and mouth and tongue before a feeding attempt. And if anyone in this room has ever met a baby, especially a hungry baby who already didn't love things in his mouth, you can probably imagine about how well that went over. And an upset baby feeds worse. So pissing him off right before a feed was high stakes. So the instructions were clear. The reality was pretty complicated. And when brain development was being threatened by not having enough caloric intake, the improving oral motor coordination, as valuable as it was clinically, was not the top priority. In hindsight, looking back, I can see that I wasn't failing. I was using discernment to make the best decisions I could while navigating something that was somewhere between hard and too hard. So, first, I want to thank this group for holding this personal story. But the point isn't about me. Here's the point I want to make. The OT didn't have this full picture. The PT didn't have the full picture. The pediatrician and the GI specialist didn't have this full picture. And honestly, we didn't have a case manager or a social worker until quite late in our journey, which would have been wildly helpful. But of the folks we did have in our incredible support team, each of them was practicing from within their own lane, which makes complete sense. That's how our systems are designed. But no one had a view of the whole. And so, one thing I often say to families I work with who are supporting a child with complex medical needs is that the experience can be a lot like being in seventh grade, where each teacher assigns homework as if their class is the only one you're taking. And it's not their fault per se that they can't see what's behind those other doors. It's a symptom of systems that are inherently siloed and sometimes fragmented. And I'm not suggesting we're here this morning to overhaul our health and education and family support systems. I mean, at least not today, right here in this room. But just naming that tension, you can almost see the shoulders release a little. And when I finally got connected with Regional Center and had a case manager for the first time, I let out a breath that I didn't even realize I was holding. And that's a picture of what it can feel like to navigate systems of care for a medically complex child. So that's a lot. Let's take a quick 3-minute break. And when we come back, we'll dive a little more into the so what and what's next. So I'll see everyone at the 36. All right, folks, welcome back. Hope you got a chance to stretch or get a drink of water. All right. So before we go any further, we're going to do an activity. This is a quick puzzle, and I'm going to split us into two groups for this one. We're going to divide ourselves using your birthday month. So if your birthday falls in an odd month, you are group A. And if your birthday falls in an even month, you are group B. And thank you so much, Leah, for dropping the two links in the chat. So there are separate links, one for group A, one for group B. We're all going to stay physically together in the Zoom room, but you're going to complete this activity individually. And group A and B are receiving different links and instructions. So in just a moment, go ahead and click your group's link. You will see a puzzle and your instructions. You'll have 3 minutes to work on it. Don't overthink it, just try. All right, ready? Okay, the links are in the chat, so please go ahead and open it. And 3 minutes starting now. All right, let's have everyone come back now, please. And I have 2 questions for you. And I want to hear from both groups. We're actually going to do our report back in Padlet. So in just a moment, you can please click the link that's coming your way in the chat, or you could scan the code that's here on this slide to come on over to Padlet. And if you've never used Padlet before, it's pretty easy. So I will talk us through it in just a moment. And the first question is, how did you feel about the task? The second question, a little more personal, how did this task make you feel about yourself? So let me quickly walk us through how to use Padlet, and everyone can please navigate your way over there using the link. All right, so here in Padlet, to make a response, you're going to simply click the plus sign that's underneath the question. You're going to get this little box. You're going to write your response here. You're going to click publish, and then it should appear anonymously right under the question. Now, please do this. Please start your response with your group letter. So if you are an A, start your response with A. If you are a B, please put B, just so that we know who is who. So let's give it a try. Come on over to Padlet and let us know how that went for you. Good. Okay, let's share the screen one more time and we'll read some of these responses together. So how did the task feel? Had to think deeper, angry because of tech reasons, confused, didn't know where to start, confused. B, felt impossible. A, failed a lot, confusing. Tough, took some thought, undoable, confused and stressed. Not enough time, annoyed, hate these puzzles. Yes, yes, yes. Okay. You're not missing the point, my friends. All right. And then how did it make you feel about yourself? Disappointed in the leader for giving an impossible task. I will own that, my friends. Confused. Wondering, does everyone else know how? Oh my goodness, these are beautiful examples of exactly what it feels like trying to do an impossible task. All right, so let's do our review. Why did we do this exercise? So first of all, we can see some differences in the experiences of our A's and B's. Let me go back and share my screen one more time here. And this is about, where does blame live? So I'm going to tell you now that A's and B's had the same assignment, the same task, but different instructions. And some folks may realize by now that this is basically an impossible task, but Group A was told to complete it, to be precise, detail matters, while Group B was told there is no solution as written unless others thought of something that I didn't even think of. But we're told to be creative, to test out approaches, to be resourceful and see what you can do. So Group A was set up to feel like they were failing. And I'm sorry, Group A. And Group B was given permission and encouragement to do their best within a hard situation. And the difference between locating the source of a problem internally, I am the problem, versus externally, I am facing a problem, can feel to the body like the difference between tiger and not tiger. So how does that relate to us as parents and as providers? When things aren't working, it's easy to locate the problem inside ourselves. Something is wrong with me. I'm failing. I'm not doing enough. We saw some of these responses in the Padlet. That's where blame lands. And that is an extraordinarily hard place to learn from, to grow from, to ask for help from, for two reasons. First, self-doubt and shame can create a kind of hopelessness. Why even try? I'm not capable, right? And second, when we feel ashamed of how we're doing, we often don't want that struggle witnessed by other people. We don't want to show up to the appointment where someone might see how overwhelmed we are. We don't want to admit that we didn't do the exercises. So we withdraw, we miss appointments, we say we're fine, because when the problem lives inside you, your nervous system reads that as a threat. So we have our amygdala, the brain's alarm system, and it starts looking for danger, while the prefrontal cortex, the part of the brain that helps us think, plan, learn, and problem solve, becomes less available. So it's harder to access our best thinking when we're busy trying to protect ourselves. We're no longer in a place of learning, curiosity, or collaboration. We move into protection, defensiveness, disengagement. And from the outside, that can look like not caring. But what if we could move the blame? I saw some beautiful questions coming in the chat, including, what helped you or allowed you to be open and to identify what was really going on, and that so many of you see that your families are struggling and might not always know how to open those conversations. So part of what I hope to do is to offer some of the tools that really help to do that. And part of it is about removing the blame, not removing accountability. So we're not trying to excuse behavior, but locate the challenge where it actually lives, which is outside the person. This feels hard because it is hard. There are real barriers, real constraints, real competing priorities, and people are doing their best inside all of that. And when we can locate the challenge outside ourselves, when we can say, this is hard because it's hard, not because something is wrong with me, everything shifts. We can learn, we can try things, we can be honest about what isn't working, and we can believe in our own ability to figure it out. We move from defending ourselves, like me against you, to problem solving, you and me against the challenge. And the tiger leaves the room. Here's what that changes in the nervous system. When the challenge stops feeling like a threat to our worth, the tiger can leave. And that matters more than it might seem because our brains actually function differently when we feel safe versus when we feel threatened. In our fight or flight mode, we lose access to the very things we need most: our creative thinking, problem solving, openness, trust. But when the tiger leaves, those things come back online. We can think, we can connect, we can collaborate. And that's what trauma-informed care makes possible, not by doing more, but by creating enough safety that the person in front of you doesn't feel like they have to protect themselves with you. I realize easier said than done, and so we are going to get into some tools and practices later this morning. But before we move on, I want to name something. Everything we just described about caregivers also applies to the workforce. When people are overloaded, under-resourced, and carrying impossible demands, our nervous system responds to that too. So again, we're going to return to this, but I want you to hold on to this idea for now. The same reframe that helps the families you serve also belongs to you. So, what makes the difference? We've talked a lot about what are the challenges. Let's talk about what it can look like when someone gets this right. I want to tell you about 4 people who were part of my experience navigating care during my early parenting season. 3 of them changed everything, and one of them is a reminder of what's at stake when we miss it. None of them were doing anything extraordinary, and that's actually the point. Rose was a nurse in the NICU, and she wasn't even my son's nurse that day, but she noticed me. I was on postpartum day 3 or 4. My milk had come in, and I was dealing with severe engorgement. I was totally overwhelmed. I was struggling, and I didn't know who to turn to. And here's what happens when you have a baby in the NICU. You suddenly go from pregnant person with a billion doctors and care team all around you to postpartum person whose baby has a bunch of providers, but you're no longer really anyone's patient. And so in passing, Rose asked how I was doing or just checked in with me. And when I told her what was going on, she didn't redirect me back to the baby's care team or tell me to call my OBGYN. She helped me. She provided information, support, and practical guidance so that I could address something critical in that moment to my own recovery and my ability to be there at the bedside. And what that meant was she saw the mom and baby dyad and saw me as a part of that unit of care, and she acted on it. Next, I want to introduce Margaret, who was a medical assistant. She roomed me for an OB appointment to deal with mastitis. And I wasn't there to be seen for the lurking postpartum depression, but it was definitely looming large, even if undiagnosed and untreated. But that particular moment in time was a unique level of chaos that I've ever experienced in my lifetime. At home, my husband was recovering from knee surgery, immobile, and just back from an eventful post-op ER visit. Our toddler was potty training, amazing timing on my part, and our infant was struggling with feeding issues of his own, and I was doing my best through teeth chattering, fever, and chills, literally just trying to keep everybody alive and fed. And while doing her intake, I spotted the tattoo on Margaret's arm. It said, "Just survive somehow." Oh, man, and when I tell you that hit me, it felt like she was this divine messenger in one of my darkest moments. And I commented on it, and she stopped. I cried, and she listened. And she sat with me in what I was carrying. She helped me feel seen and heard in a way that nothing else had that day. And she didn't fix anything. The challenges didn't go away. The mastitis resolved eventually. The depression didn't, at least not for a while. But I left that appointment feeling like a person, not a chart, not a problem, a person. Elizabeth was a lactation nurse who had seen me for far more appointments than I can count, trying to work through the feeding challenges with my son. And nothing was working. It just all felt like too much. And one day she moved me out of that bright exam room with the scale and the hard chair and the clinical formality of it all. And she brought me into her office. She had a couch next to her desk, and she just told me to sit and relax. And we let my son do what he needed to do without the time pressure or the weight of being observed and assessed. And frankly, she didn't have a new clinical solution that day, but she created conditions where my nervous system could settle enough to just be with my baby. She welcomed all of me into the room, and not just the part that could fit into a 15-minute scheduled encounter. Sometimes the most important care isn't what fixes the problem, it's what helps someone keep going. And she did that for me that day. And then there was Jen. Jen was an OT, yet another OT actually, doing feeding therapy with my son. And she was warm with him, skilled, clearly good at her job. But her demeanor with me was different, professional, but distant. And when I tried to lighten the mood or connect, it didn't land. When I asked questions, I actually felt like I was a burden or it was an interruption. And I left that appointment feeling like a chauffeur. Remember when I started this by saying babies don't drive themselves to their appointments, but I felt like I was an observer or even a nuisance, frankly, as if this intervention would magically enter his tiny little body without me playing a role in every aspect of that care. And I felt unseen, devalued. Honestly, I left with rage and sadness competing for space inside my rib cage. And in that silence, the absence of warmth, curiosity, or any acknowledgement of just how hard this was, the meanest voices in my own head got louder. You're failing, you can't do this, you're not enough. Her demeanor did not create those voices, but it left nothing to push back against them. And I didn't go back. And honestly, I'm realizing my track record with OT is real bad here. But point being, the care for my son in that room was good, but I wasn't in that room. And without me really fully in the room as a confident and engaged partner in my son's care, the intervention couldn't do what it was designed to do. And this is not just about feelings. This is about outcomes. We can have the best clinical practices, the most evidence-based interventions, the most skilled providers. And if the caregiver isn't resourced, seen, and supported enough to show up as a full partner in that care, we're not gonna get the outcomes that we're working toward. We have funding streams dedicated to improving outcomes for children. In California, in our counties, I feel very fortunate that we have some of these dedicated forms of support and programs. But if we are pouring that intervention and that investment through a sieve rather than a cup, our children aren't getting the benefit they deserve. So these were 4 people, 4 different roles, 4 very different moments. Rose, Margaret, and Elizabeth weren't doing the same thing. Rose noticed spontaneously. Margaret offered emotional presence. Elizabeth changed the environment. What they shared was this: they saw me as a part of that care unit, not a bystander, not an obstacle, a person who mattered to the outcome. And that's what I mean when I say care for the people who care for the people. And Jen, this is a made up name, by the way, Jen reminds us what's at stake when that doesn't happen. Families make decisions about whether to come back, whether to trust, whether to try. And those decisions, made in the quiet aftermath of how they were treated in your room, are where all of our best intentions either take root or don't. It is how we show up that shapes those decisions every single time. Let me take a moment. We're about to move on to skill building, but I would love to take a moment and just quickly peek at questions in our chat and see if there's anything that we should pause and review. Our A's and our B's. Sorry for the tech challenges, friends. Yeah, what made you feel comfortable enough to be open when you were just going through it? So the tools we're going to talk about in a moment, I really do hope. And I also want to acknowledge race, power, and privilege. It is really hard to say you are failing or you feel like you are failing. And especially when you're dealing with depression, anxiety, or sort of PTSD and overwhelm. The sense that you really are failing can be, again, even louder and even meaner than maybe our better judgment in another situation. So I really want to acknowledge that I think looking at basic needs, looking at the full picture, and looking at community context is really important. Again, I work with a lot of NICU families, and I think immigration status is going to be something that affects how people feel safe, who they feel safe with. There are other factors. How people have been historically treated in these health systems is going to shape what it means to create that kind of safety. I think the role for us as systems folks and members of the workforce is not to put the outcome on us. The outcome is not, if I did my job well, that person will feel trust and safe. The goal is it's my job to make sure that I am expressing and conveying safety. And I'm not accountable for whether or not that person can hold it. We do our best. We do our best today, tomorrow, and the next day. And over time, there's a cumulative impact of the way that we show up. It doesn't necessarily happen in one visit, in one time. And I'd be lying if I said it was the same recipe for every person who walks through your doors. Okay, I'm going to move us on to tools, but I definitely don't want to miss anything in the chat. So please keep these comments coming. And we will hold some dedicated time for questions at the end. We're doing pretty good on time. All right, so skill building. We've talked about what it feels like to be a caregiver carrying an invisible load. We've talked about where blame lives and what it does to the nervous system. We've seen what it looks like when someone gets it right and what's at stake when they don't. And now I want to talk about what we can actually do. And I want to start with not a list of new things, but a lens. So I want you to imagine this picture as the intervention. This might be the recommendation, the referral, the classroom strategy, the home exercises, the feeding plan, the developmental guidance, whatever it is. And the water is the support, information, or care we're trying to deliver to the child. But in early childhood work, we're almost never pouring directly into that child's mouth. The intervention moves through the caregiver first. The caregiver is the cup. Some days, that caregiver has capacity to receive, hold, organize, and carry what we're offering. And some days, the cup is already completely full before they even walk into the room. And some days, the nervous system is so overloaded that things are moving straight through. Not because the caregiver doesn't care, not because they're resistant, not because they're non-compliant, but because the person we're asking to carry it is overwhelmed. And this is the part I really want us to notice. The pitcher can be doing a perfect job of being a pitcher. The recommendation might be evidence-based, the provider might be skilled and compassionate, the intervention itself might be excellent. But if the caregiver doesn't have the capacity to receive and carry it right now, the child may never actually get the water. And when the real cup overflows, we don't blame the cup for overflowing. And cups don't sit there feeling ashamed that they couldn't hold more, but parents do. But here's what's also interesting about a cup. When we can actually see how full it is, we can take a moment before we pour. We suddenly have options, right? We can pour less. We can help them find another container to hold some of it. We can look together at what's already in the cup and ask, is any of this ready to be set down? We can get creative. We can make multiple trips with smaller amounts, right? That's what our Group B friends had to do with the impossible task. They had to adapt, prioritize, get creative, make decisions about what was actually possible. And the difference wasn't the task itself. It was whether or not shame got attached to the adaptation process. That's what trauma-informed practice looks like in real life. Not just adding more, assessing first, and then collaborating on what's possible. So let's do another chat prompt. Before we go into the tools, a quick pulse check. In the chat, finish this sentence in 1 or 2 words. When a family seems overwhelmed, I tend to blank. Give reassurance, get curious, acknowledge how they're feeling, check in with the family. Great. Be a good listener. Beautiful. Great. Well, all of these are real responses, and these are already trauma-informed practices. And some of these we're going to build on today. Yes, beautiful. Ashley, want to fix it. Yep, thank you. Offer emotional support. Validate and ask them what they feel like would be helpful. Beautiful. Great. All right, so I want to share 6 tools today, and none of them are new skills that you have to learn from scratch. Most of them, frankly, are probably things you already do. What we're going to do today is make them more intentional. So let's start with tool number 1. Zoom out before you zoom in. Before you get to the business of the interaction, pause and ask one open-ended question about the whole picture. Something like, before we get started, how are things going right now? Or walk me through what a typical day looks like for you. You don't need the whole story. You just need enough to know how full the cup is before you start pouring. And sometimes just being asked is the intervention itself. So let's drop in the chat. What's a zoom out question you already use or wish you had time to ask? Drop it in the chat. Let's see a few. How's your day going? Yeah. Kind of like we did with our scale of cats, right? It's like, hello, human. What's your vibe? What are you bringing in with you today? How's your communication with the medical team? Yeah. Reminding them of the resources that they're already connected to and demonstrating that you're supporting those connections that already exist. That's great. How is your heart today? I love that. Yeah. These are beautiful. I love these. We'll keep them coming as we move on. I love seeing this, and I want you guys to get to enjoy all of the wisdom that's already here in this room today. All right, number 2, normalize before you advise. Before you offer a recommendation, name the difficulty. Most families navigating this find it really hard. What you're managing is a lot. It makes complete sense that this feels overwhelming. This does something important. It locates the challenge outside the person before you ask them to take something else on. It says the difficulty belongs to the situation, not to you. And when the shame leaves the room, even briefly, there's more space for the person to actually hear what comes next. I think this was probably the biggest one in terms of what I needed from Made Up Name Jen. I needed her to see that I was trying, that I was human, that I wanted to connect with her person to person, and it just wasn't happening. And I felt like in order to be able to say, I get the program and I don't know how to do this, I needed some signal from her that there was enough safety for me to be able to show up. Um, and it feels really amazing when someone else can see and acknowledge us, right? That like, I know this feels hard. It feels hard because it is hard. All right. Number 3, collaborate on what's possible. Here's a shift that can change everything. Instead of, here's what you need to do, try, here's what we know would help. How might this realistically fit into your life right now? That one question does a lot. It communicates that you see them as a partner, not a recipient. It opens the door to honesty about what's actually possible. And it positions you both shoulder to shoulder against the challenge rather than across from one another. And sometimes what comes out of that conversation is a modified version of the recommendation that actually gets done, which is infinitely better than the perfect recommendation that doesn't. So I'd love to hear from folks. Has there been a moment when collaborating with the family led to a creative solution that you wouldn't have thought of alone? If so, drop it in the chat, even if just a few words. As a doula, I love it when I find out if one of the biggest challenges a family is facing is something that I can support them with. I'm like, really? That's the thing keeping you up at night? Like, I got you, you know? That's not always the case, but sometimes, again, having more honest dialogue and reflection opens doors to things that you might have had no idea that was the primary need or barrier or challenge. All right. Number 4, name the hard. Sometimes the most powerful thing you can say is the simplest. This is a lot. Not a question, not a solution, just an acknowledgement that what they are carrying is real. 2 seconds, enormous impact. I see Brenda in the chat. I think it helps people feel in control. Exactly. Exactly. And that is so huge in terms of how they feel, their role in their care and experience. Yeah. Support by advocating in expressing concerns. Yeah. I'm concerned for you. I want the best for you. Yeah, these are beautiful. Number 5, prioritize instead of pile on. All right. So remember 7th grade. And if you're one of 5 providers working with a family, and I guarantee you, if you're dealing with families with medical complexity, 5 is average, if not a low ballpark. And each of you sends them home with 3 things to do. That family's leaving with 15 tasks. So name your top priority explicitly. If you can only do one thing this week, it's this. And then follow up with one simple question. How feasible does that feel given everything else you're juggling? And are there any barriers we should plan around together? We also talked about trust and safety before, right? The first time you ask this, they might say, no, 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 I got it, everything's fine. But maybe the second or third visit, they'll be like, well, actually, you know? And so again, trust and safety are built, and these practices, it's not magic. It is something that we do every time with every interaction, and over time, we build a sense of trust and safety. Now, I also want to acknowledge you may not be able to solve for everything that's competing for their attention. By naming the tension together, you shift from handing someone assignment to building a plan. And again, a realistic plan that gets done is worth infinitely more than a perfect plan that doesn't. But this is where it gets nuanced. Sometimes what's competing for a family's attention isn't another appointment or another recommendation. Sometimes it's housing, food, transportation, childcare, immigration concerns, safety, the very real realities of daily life. And some of those challenges can be addressed with the resources and support you may be able to provide or direct them to. And others can't be solved nearly so easily. Either way, these factors are shaping what's realistically possible for them in a given moment. And some weeks, another priority will legitimately come first. And when that happens, the stance that serves families best is something like do what you can, Some is better than none. And if none is all you had this week, we hold that with compassion and we try again together next week. And that's not lowering the bar. What we're working towards stays. What flexes is the timeline and the shame. Here's the thing though, the more trust you build with a family, the more honest they'll be about what's actually competing for their bandwidth, which means you can actually prioritize together rather than everyone just sort of assigning homework in the dark. All right, tool number 6. This is my favorite and probably the hardest. This last one is about you, not what you say, but how you show up. Remember that your nervous system is in the room too, and it's communicating with the nervous system of the person across from you below the level of words. This looks like a slower pace, a quieter tone, unhurried eye contact, a moment of stillness before you begin. And these are not soft extras. They are clinical tools. They signal safety, and when someone feels safe, remember, the tiger can leave the room. You don't have to be perfect, and you don't have to have all the answers. Sometimes the most regulated person in the room just needs to be present. And I alluded to this before, but I also want to name again, signaling safety is not the same thing as expecting trust as the outcome. Trust is earned over time. And for families who have experienced racism, inequity, bias, or harm within systems, that trust may take longer and require more consistency. It may never come. And our work is to keep showing up in ways that are safe, respectful, and trustworthy without expecting immediate openness in return. So, welcome any questions in the chat. And now I'd also like to do a quick Zoom poll and just ask which of these tools feels most natural to you right now. Nice, look at the spread. I love that all of the tools are represented here. This is beautiful. And it looks like zoom out before you zoom in and signal safety with your presence are showing up as our real leaders in terms of what's already feeling natural and accessible. Wonderful. All right. Well, I love seeing this range. And the ones that feel least natural are often the ones that systems make hardest to do. And that's not an accident, actually. That's what we're going to talk about next. So these tools already live inside of you. You can bring them to your very next interaction. But I want to be honest about something. Some of what makes these tools hard to use isn't about skill. It's about the conditions you're working in. And that's what we're going to talk about next. So I'm going to transition to talking about the workforce reality and systems. We've spent most of today talking about caregivers and families. We talked about nervous system and a little mini brain science 101. We talked about overload and what helps people feel safer, more regulated, and more able to engage. We've talked about practical tools, small things that can genuinely make a difference in real interactions. And I absolutely mean this sincerely. Those tools matter. But I also want to be honest about something. The tools we've talked about today are intentionally simple, but simple is not the same as easy. These practices ask us to stay curious, connected, and regulated in environments that are often stressful, under-resourced, and demanding. And so when these tools feel difficult to use consistently, again, it is not always about skill. Often it's about the conditions people are working inside. And I think it's important to name that clearly, not to blame and not to spiral into hopelessness, but because naming reality accurately helps reduce shame for us as well. So earlier today, we talked about caregivers as the soil in which babies and young children grow. And if caregivers are this nutrient-rich soil that supports children to thrive, Everybody in this room, you are those who are helping to tend that soil. You are the nurses, educators, home visitors, family advocates, therapists, medical assistants, social workers, frontline staff of all kinds. But the people tending the soil don't exist in isolation either. Relational care thrives in healing-centered environments. Everything we've talked about today, the nervous system, the tiger, the full cup, what it feels like to be asked to do more than is possible, is not just the story of the families you serve. It's your story too. And we are not machines that just pump out services or best practices. We are human beings working inside human bodies with a nervous system that responds to stress, overload, uncertainty, and chronic demand in the same ways we've been describing all day. When there isn't enough time, when the documentation never ends, when you want to slow down and be fully present with a family, but the realities of the day make that difficult, when you're working incredibly hard and it still feels like it isn't enough, that activation is real. And earlier we talked about what happens when caregivers locate the problem inside themselves. The same thing happens to the workforce members. When the system is under-resourced, when conditions make it genuinely hard to provide the kind of care you know families need, it can be easy to internalize that as personal failure. Again, I'm not doing enough. I'm not good enough. Or caring means I have to give more, right? Has anyone else felt that one? That was mine for sure. And I say this a lot. If it feels like too much, it's probably because it is. And that strain doesn't belong entirely to you. I think our social sectors, healthcare, education, nonprofits, have become far too comfortable with this idea of doing more with less. And let me say loud and clear, that is not the answer. Because eventually, nervous systems respond to that chronic overload too. And when we fail to name the structural conditions that create these gaps, we can end up placing responsibility on the individuals who are already doing everything that they can. And so you're allowed to name that. You are allowed to recognize limits clearly. And you're allowed to say no sometimes, not because you don't care, but because saying yes to everything is not sustainable care. It's a path to burnout. And as many of us know, burned out providers cannot provide the regulated, present, trauma-informed care that families need. So I want to come back to Margaret for a moment. The thing she did that day that stayed with me was incredibly simple, but its impact was huge. She slowed down, she listened, she stayed with me for a few extra minutes. She actually told me a little bit about her own story and how she ended up with that tattoo on her arm. It was really beautiful. And at the time, I don't think she realized how much that moment mattered to me. In fact, I know she didn't. Years later, I tracked her down and I asked her to have coffee with me. And she gave me her permission to share her photo and to share that story. And I told her what that moment had meant to me. And she said, I always hoped I was making a difference, but you really never know. And then I asked her, what would systems need to look like for this kind of care to become the norm? And she said, more time. She actually told me that she had been chastised for taking too long to room patients. So the very thing that made the difference in my life was the thing she was being told not to do. And I think there's something important in that. Every interaction in a system has the potential to shape someone's experience, either positively or negatively. And if we know these interactions can have that kind of impact, then we also have to think about what makes those kinds of positive interactions possible. Because the goal cannot be just asking individual people to be exceptional in systems that don't support relational care. So here I want to touch on boundaries and sustainability. Many helping professions operate inside systems that are imperfect, overstretched, and not always conducive to workforce well-being. And when people care deeply, it can be easy to start internalizing systemic strain and feel pressure to do more. But some of what you're carrying isn't yours to fix. The interactions still matter enormously, but part of sustainable trauma-informed work is learning how to stay grounded without absorbing the full weight of the system into yourself. Saying no is not a lack of commitment, and setting limits is not a lack of compassion. And when a family is having a hard moment, when someone is guarded or reactive or difficult to reach, it's important to remember that there may be more happening beneath the surface than you can see. Remember what we know about nervous system underload. Remember the tiger. So the parent who is short with you at the appointment might have spent the morning fighting with their insurance company or gotten a scary test result. They may be running on 3 hours of sleep for the fourth night in a row. And you can hold compassion for that without absorbing it as your own. I know that's hard. That's a skill. And like all skills, it takes practice and it takes support. And it also requires systems that support workforce well-being, not just individual endurance. So next, I want to speak directly for a moment to anyone in this room who holds positional power, supervisors, managers, directors, leaders of any kind. And if your organization or system leaders are not in the room today, send them this slide deck. Send them my way, because this is part of what we need to be talking about. What we've talked about today applies to the role of leadership in a specific way. First of all, you're human too, and you are navigating your own complex systems. So this looks like boards, funding streams, regulations, competing demands coming from above and below. So the tiger visits you as well. We recognize that. And the wider your sphere of influence, the more people feel the effects of how you show up. But second, the conditions that allow frontline staff to show up as regulated, present, trauma-informed providers, those conditions are yours to shape. That means listening to your staff, to families, to communities you serve. And I don't mean waiting for feedback to arrive in surveys or annual reviews. I mean actively creating the conditions where honest input, trust, and real collaboration can exist. And if you're not hearing from your teams, that's data too. And again, this is a topic I could spend a whole session on. It also means resourcing relational care. If the metrics you measure don't reflect the values you hold, that's a gap worth examining. It means protecting time. Margaret needed more time. That's a leadership decision. It means asking, where are the preventable frictions in this system that make the work harder than it needs to be? And then within your sphere of influence, working to reduce them. And you may not be able to fix everything. These are immensely complex systems, but you can listen, you can advocate, you can make sure the people doing this hard work feel seen and held the same way we're asking them to see and hold the families they serve. Because a dysregulated system cannot consistently deliver regulated care. So I want to do a show of hands. Who had a moment while we were reviewing these tools where you thought to yourself, yeah, that sounds great, but ... Maybe something that immediately came to mind that would make it difficult to put into practice. I'd love to start just seeing with a show of hands. Did anyone have that kind of reaction? Yep. Well, I wouldn't be surprised if everyone in this room had a hand raised, or at least had some aspect of that go through their minds. Go ahead and drop it into the chat. What is one thing that came to mind? What felt like it could potentially get in the way? Mm, program guidelines and deadlines, families giving up. Solange, yeah, that's big. Policies and procedures, yep, yeah. Bureaucracy, school districts, and healthcare systems are some of the hugest system entities that come with a lot of rigidity. Yeah, yep. Beautiful. Well, thank you. I personally find it so important to name these things because a lot of these are bigger than I have the power to change. And when I keep them just kind of rattling around inside my brain, it can be really overwhelming. And I don't want to minimize how real and significant these things are. These are absolutely the conditions that shape the work. And some of these live outside of our sphere of influence. Some of these live at the leadership, organizational, or systems levels. And naming that distinction doesn't mean that the systems issues don't matter. It means we're getting clearer about what belongs where. So, where does that leave us? It leaves us with two things that are both true at the same time. That systems need to change. That work is real and ongoing and belongs to all of us, especially those with power to shape it, which I would actually say is all of us. And small human moments still matter enormously right now in your next interaction. You don't have to wait for the system to change to make a difference. Rose didn't wait. Margaret didn't wait. Elizabeth didn't wait. They showed up inside imperfect systems with imperfect resources in imperfect moments, and they changed someone's experience of care. And that is available to you today, tomorrow, in your very next encounter. So let's close by thinking about what that looks like for you. We covered a lot of ground today. Brain science, caregiver reality, what it looks like when someone gets it right, and what's at stake when they don't. We talked about some practical tools and the very real conditions that make this work hard. And I don't want to overly summarize all of that. We've lived it together for the last 2 hours. But what I want to do instead is invite you to land somewhere with it, something that's specific and something that is yours. Before we move on to a final reflection, I want to come back to what we named just a moment ago. When we put those barriers and constraints into the chat, a lot of them live outside our immediate sphere of influence. So let's give those a home, all right? If the solution to that challenge requires a policy change, a funding decision, a systems change initiative, a revolution, or a letter to your senator, we are going to lovingly put those in a separate bucket for a moment. Again, not because they don't matter, because they absolutely do. And not because we're going to stop caring about them. We are not going to stop the advocacy work that we all are doing on behalf of children and families. But for this last activity, we're going to ground firmly in our sphere of influence. Part of leaving this work with a sense of grounded agency is knowing where to place our energy. And some of the challenges we named are rooted in really big problems. Again, we've talked about basic needs struggles that many of our families are facing, or policies or practices that may not align with the way we intuitively want to operate. And if you're anything like me, it's easy to vacillate between two places. One is over here, and it's like despair. This is so big, I can't fix any of it. And then over here, is what ends up being distraction. It's all so important. I have to fix it all. And neither of those really serve me well in terms of leaving me with much room to act. So, for the next few minutes, I want us to focus on the place where agency lives. This is the place where your energy can become action. the place where you can take what you learned, what you've noticed, or what you've connected with today, and apply it where it'll make the greatest impact from exactly where you sit right now. So I'm going to give you 3 minutes of quiet. No need to type in the chat, no sharing just yet. Just sit with this question. What is one small shift I can make in my very next interaction with a family? It doesn't have to be big, it doesn't have to be perfect, it just has to be honest and doable. And maybe it's asking one different question, or slowing down one moment, naming the hard before offering the solution, or prioritizing instead of piling on. Whatever it is, write it down. Write it somewhere you'll see it again. So I'm going to give us 3 minutes of quiet here. So now I want to invite you to share what you came up with, not with just me, but with each other as well. So we're going to drop one more Padlet into the chat. Oh, beautiful. Thank you, Leah. So click on the Padlet. Again, anyone else who is not able to access Padlet, please feel free to drop in the chat and I can shuffle things over from the chat into the Padlet. So here, same process for adding, just click the plus button, enter your response, and let's take maybe 2 minutes for posting in the Padlet and then give everyone a chance to read and review others' responses. These are beautiful. I'm loving seeing these come in. So now I want you all to take a moment and read what others have shared in the Padlet. And Padlet has a feature where you can react or comment. So let's just give each other a little bit of love. If there's something that you see written here that resonates for you, you can hover over that little smiley face and you can give it a heart, thumbs up, or reaction, or you can type something in a comment below. I really want to just honor and celebrate all the wisdom and experience that already lives here in the room. I'm going to screen share the Padlet if there are folks who aren't able to view it. And let me refresh so we can get the most current comments here. Yeah, this is beautiful. Slowing down, I'm seeing that as a real theme. Being present. Yeah, check my pace, my tone, and my body language. These things are not easy. They may be simple, they are not easy, but so important. Shift to assume that the system has broken down rather than the person. Yeah. Thank you all so much. So this is incredible. I want to just take a moment and witness what has happened here in this room. A whole community of people all across different roles and different settings, fully committed to showing up a little differently for the families they serve. That is huge. I'm going to stop the screen share for a moment so I can see everybody's faces again. And I'd like to open it up for a moment. Is there someone who wants to unmute and share not just what your shift is, but why it landed for you today? What was the moment in this training that shifted something?
Can I say something?
Yes, Marlon, please go ahead.
I was actually looking for the hand and I went to the microphone. So I think that the example that you gave, it just hit where I am right now because we are working with some moms who are actually going through transition, babies coming back from the NICU and going through the same, feeding tubes and doing, and babies just very delicate, and moms just sobbing and trying to understand what is it that they're doing wrong, what is it, and we on the other side trying to understand them to see how we can actually be there genuinely versus looking at your wrist or looking at the clock or looking, because we do have those, like, okay, it's 8 o'clock, you gotta clock out, you gotta do this. But then when we're working with the family very closely, we know that when the clock hits 8 o'clock, we don't necessarily stop because there is probably a transition that probably started 15 minutes before 8 o'clock, and you're still going another 15 minutes. So I think honoring that concern speaks for how we want to make that difference and know that we did, whether the moms remember us or not the following day, or whenever there's so many other things that they have concerns about, their own sobriety, their own recovery, and the many other things that they have to deal with. So just having that pause, and I love how there is a off tiger song for either the families, because I like it for little ones, for the older toddlers. It's just a combination of seeing the entire family, I think. Because I know that when we have babies, for some of us, like everybody else goes straight to, oh, how is the baby? How is the baby? How is the baby? Which is something the moms love. And then yet in your moment, you're like, "But what about me?" So
Yeah.
I think that was just like, wow, this is amazing. This is like exactly. I would like to like just asking those questions, seeing, knowing that I am really seeing and not getting frustrated or this like I is that overwhelming. So what I am seeing and what I have read in the last few days is that overwhelmness that you were describing. So I just totally appreciate all these tools because everyone just kind of fits in, and sometimes you just have the intentions to use them, but then the order in which they go in may be different. I,
Yeah.
that's what I wanted to say. Thank you.
Well, Marlene, thank you so much for sharing that. I'm really glad that it resonates with you, and I imagine others might feel similarly. Do others want to respond either to what Marlene was sharing or anything else that resonated for you specifically?
I would love to share. I think I was really connecting, sorry, Marlon, I think, what Marlon was saying, because when babies come, we do forget the mothers. And I think you said something too about naming reality accurately helps reduce shame because it can really feel like you're going crazy. Like you birth a child and then, like all the energy, the resources, the intention is diverted to the child. But the mother is, a lot of mothers come away with a lot of physical trauma, like their body is physically traumatized. And then also just like orienting yourself now as a mother, like you have a whole new layer of your identity. And there's a lot of times very little care taken with women who have just birthed babies. And I just think that represents to me that women in general are discarded once their use is kind of fulfilled a lot of the time, whether that's being a mother, whether that's rearing the child, bearing the child, or taking care of the child. At like any point, like women get left behind a lot of the time, and then even more so if you're black, brown, disabled, like all these other things. And it it does make you feel crazy, I think. A lot of the moms that we work with feel genuinely crazy, and I think it can drive you crazy to feel ashamed and have no one recognize you in that way. So I was really, really connecting to your story about Margaret and all the other people who you encountered when you were a new mom.
Thank you, Maya. Thank you. If I could put all that on a t-shirt, I would wear it every day. That was beautiful. I think we have time. Maybe let's hear from one more person, and then I do want to leave some additional time just for other general questions or comments. Does someone else want to share what resonated with them today?
I would like to share. So I felt like, actually for me, it was the aha moment because like in our workforce, we are here and we're trying to best helping others, but we also forgetting about ourselves as a providers and our own good state, because we are mothers too, you know. So, and we going through the trauma daily in our second shift, and we're dealing with the trauma of others in a real workforce. So, which is very heavy to kind of balance it and don't get overwhelmed over stories of others and don't get emotional and still be here present and being able to help. How can you help if you are withdraw yourself as a person, right?
Yes. Olina, thank you for sharing that. I mean, that resonates deeply with me. I worked for a nonprofit for many years, and then I've worked with nonprofit organizations, over the course of the last 20 years. And I feel like there really is this sad underbelly of glorifying overwork, that in these helping roles, we are so mission driven that we act as if caring for ourselves is somehow not caring for the mission. And I think that reframe is so important that no, not resourcing ourselves to be able to show up and do the work in the way that enables it to have an impact and to have somewhere to land is actually frankly, not doing justice to, again, these incredible resources and programs we have. We owe it to the children. It's because we care about infants, families, and children that we need to be resourced and able to sustain ourselves in this work. So I'm so delighted to hear you capture that, and I'm sure many others feel that sentiment as well. I want to take a moment to close and then we'll go to questions. I really want to share my gratitude. You all showed up in the middle of everything that you're carrying, your caseloads, classrooms, your families, and chose to spend 2 hours thinking about how to show up better for the people that you serve. And that's huge. You are going to have many of these moments, like Margaret, like Rose, like Elizabeth, where you are showing up human, present, and paying attention. I'm certain that you already are more than you know. And even if families may never tell you, they might not even realize in the moment how much it meant, but it is there. It is there. You are not just doing your job, you're shaping whether someone feels safe enough to keep going. And I want to thank you for being here, for this work, and for caring about the people who care for the people. And I want to close by saying that I call myself a bridge builder and a gap filler. And that is truly because we cannot do this work alone. So I welcome you to connect. Let me know how this training landed, what you'd like more of, and ways that you're hoping to shift practices and culture in the spaces that you move through. I am here for it. And so we'll use the last few minutes for some questions. There will also be a handout coming your way and the post survey. And I really appreciate everybody's time, your participation, your feedback. And now I'd love a chance to just hear more of your questions and insights.
Just like to take a moment to open up the room to any questions, comments. We do have a couple of minutes to share here. So open up. Welcome to come off mute or drop a comment or question in the chat.
Hi, I just wanted to say there's so much I got from this training. I really appreciate your teaching style. I appreciate the opportunity to look at it from like a micro lens, a macro lens. I really appreciated your slides. Sometimes I get so caught up in like making sure I get every slide. Your slides were like cohesive and you were able to give us something to get a tidbit, but you had just such a wealth of information that you added to that. I just wanted to say, in addition to the content, I just appreciated your presence, and I really got a lot from this training. So thank you.
Thank you, Jamila. I really appreciate that. I'm really glad you could be here today. Any other questions? Anything that feels still sticky or tricky or unclear?
I have a question. How's your baby doing now?
Oh, thank you for asking, Solange.
Yeah.
My baby is 11 and he is beautiful. He has the longest eyelashes you've ever seen on a human. He's skinny. He's remained skinny. Weight has been his thing. And the primary resolution of his challenges was time.
Mhm.
There was never, you know, any diagnosis that revealed or changed things, and he's doing beautifully. And he trains in our family martial arts school, so he might be skinny, but he's going to be the most powerful little ninja baby going off to middle school next year. Thank you so much for asking.
Mai, thank you for sharing.
Oh yeah. I mean, this work is my labor of love. I came from this sort of academic and public health and data and research and evaluation, and I was given this opportunity and this lane, and it has become so clear to me that this work is my purpose. So I am, like I said, I'm a collaborator, I'm a bridge builder, and I'm passionate. I'm passionate about doing this person-centered healing work from the ground all the way up.
Thank you.
Thank you, my dear. All right. Well, if we have any other questions, we'll take a moment to address them. And I think, Catherine, when you're ready to close us out.
Yeah, I just want to really take a moment here to thank our presenter for today, Shahla. Thank you so much for this lovely, wonderful presentation and for sharing your story. And thank you all for being with us and being engaged and for participation and for all the work that you do out there to serve the community. So I just want to share gratitude for everyone. And thank you all, and we hope to see you next time. Have a great day.
Thanks so much, all.